This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 20, Airway Anatomy and Physiology. And after completion of this chapter, you will be able to understand the route of oxygen molecule takes from the oral and nasal cavities to the alveolar capillaries, the anatomy of the airway structures as viewed with the laryngoscope, lung volumes, capacities, and mechanism for negative pressure ventilation, composition of air and the physiology of the internal and external exchange of respiratory gases, and key anatomical differences between the pediatric and adult patients. So, airway anatomy. The airway is divided into an upper and lower airway. The upper airway anatomy begins with the nares and mouth and extends to the glottis. The lower airway extends from the glottis to the alveoli. This is figure 21, overall respiratory system anatomy. And the airway is divided into two sections, upper respiratory system and lower respiratory system. So your mouth, nose, your oropharynx, epiglottis to the glottic opening is essentially the upper respiratory anatomy, and the lower respiratory anatomy, left and right lung, the trachea, which is in the anterior portion. So whenever you look at this under laryngoscope, the top hole is the one that you're going to hit, or going to need to hit. Your bronchus, left and right main stems, and the right main stem is kind of lined up a little bit more than the left, so statistically, whenever we drop a tube, if we go a little deep with it, we'll push it in the right main stem, which decreases our lung capacity by about half because we're not really ventilating the left lung at that point. We're ventilating the right lung. And then all the way down to the capillary alveolar level, which this is a sinus, and we'll talk about that here in a second, or a sac-like structure. And it's surrounded by capillaries, and these capillaries allow us to load oxygen onto the hemoglobin molecule and offload CO2 kind of simultaneously. This is a blown up picture, figure 20.2 of the upper respiratory anatomy, and just a quick overview of this. The nares have these mucus and hairs in them, which are kind of protective, so as air comes into here, if there's any foreign particles in there, it'll get trapped in the mucus and the hairs. The hard palate, which is the separator between your mouth or your oral cavity and your nares, you have a bony structure up front and then a soft structure of tissue towards the back, cartilage and skin. Now, the soft tissue at the back is called the soft palate, and the bony structure up front is called the hard palate. Now, this is the oral cavity. And the tongue. The tongue is probably our most aggressive enemy, if you will, whenever we're trying to provide airway control. If a patient is unconscious, they generally lose tongue control. The tongue will fall to the back of their throat. So it will fall to the posterior area if they're laying supine and kind of occlude the airway. That's why oropharyngeal airways or nasal pharyngeal airways work so well. Bypasses the tongue. The uvula, which is a little dangly thing in the back, and then the back of the oropharynx. Now back here you have tonsils and all kinds of stuff. I'm going to clear this off so it doesn't get so busy. Down to the epiglottis. Epiglottis closes the airway during swallowing and opens it during breath. Now this again is the anterior and posterior sections. So the hole that you're trying to hit during laryngoscopy, or to provide an ET tube, is on the anterior section. This is the larynx, and this would be also the glottic opening at this level right here. Thyroid cartilage is going to be the big cartilage up front, and on top or superior, the first one that you feel, and which is the Adam's apple also. The cricoid cartilage is going to be the first cricoid ring. Between them is the cricothyroid membrane. This is where we apply surgical airways. Back to the posterior area here is the esophagus, and the anterior portion, or the anterior hole, is the trachea. This is a blown up picture of the oral cavity. You essentially have 32 teeth, 16 on the upper and 16 on the lower, not counting the wisdom teeth. The problem with this area here is sometimes we can actually get tonsils that are very large that are on both of these sides, and it decreases our airway lumen here. The tongue, again, always one of our great enemies, which can fall to the posterior. So something to look at. Always make an assessment of what's going on. We can actually tear up the upper and lower lips during trauma and have blood in the oral airway as well. This is the hyoid bone and muscular attachments. This is figure 20.4 in your book. And what's miraculous about the hyoid bone is all of the ligaments, voice structures, and airway structures attached to it. So this is also one of the bones that we actually break whenever the person is suffering from a hangman's injury. When the rope pulls, the bone is kind of free-floating. It doesn't articulate with another bone, so it'll break this bone. And again, here's some other structures: our thyroid cartilage and our cricoid cartilage, and there's our cricothyroid membrane right there. This is viewed figure 20.5 A through C, and this is laryngeal anatomy as viewed through a laryngoscope. So whenever we apply the laryngoscope would be applied here. And if we use a curved blade, it'll actually go in the vallecular space. If we use a straight blade, we kind of take slices out until we see this opening. Now these will be covered with tissue, but these are vocal ligaments, and this is what provides attachment of our vocal cords. This is the glottic opening here, or the glottis. So we should see this triangular shaped hole whenever under laryngoscopy. Now, one of the biggest faults that people actually have is they'll go too deep with a laryngoscope. So if you go well past this, and your laryngoscope is obscuring your view, very simply, it's hard to see it at that point, because as you pull upward, then all you see is the esophagus. Again, thyroid, cricoid cartilage. This right here is our cricothyroid membrane. So under surgical removal of the tissue, what we generally will see is we'll start to see these structures. And what these structures essentially do is they provide protection of this area and give us the ability to make the airway more rigid. But under trauma, while we're talking about this area, under trauma, this entire area can also get broken, smashed, kind of crushed. So that would be a definite clinical indication for providing a surgical airway. Would be upon palpation of the throat, we feel a bunch of crepitus. This is a side shot. Cartilage of the epiglottis, thyroid, cartilage, cricothyroid ligament, and this would be what we're cutting through in the cricothyroid membrane. Superficial anterior neck anatomy. Major points in this are that you have very large vascular areas on both sides of the neck. In addition to that, whenever we're providing surgical intervention here to get a surgical airway in place, we do have vascularity running across us. This can be a little different. This can be a little superior or a little inferior on any patient. So as we make the vertical incision and we separate the tissues back, be sure we're looking for vascularity or the vascular beds there. This is the lower airway anatomy, and this is from the tracheal level or the glottic level. This is the carina, which is an important term, which means essentially this is the area to where the left and right main stem bifurcate or break into two parts. And then all the way down to the alveoli, which this area here is covered by capillaries to allow for gas exchange to occur. This is an acinus. An acinus is a sac-like structure that, in our case here, this is where air goes in and CO2 is expelled. Now, a very brief overview, we'll talk about this again here in just a second from an atmospheric point of view, but there is more oxygen in the incoming air than there is in the returning sample. So what happens is simply diffusion from an area of higher concentration to an area of lower concentration. We get a movement of oxygen that moves into the tissues. Now, since the hemoglobin molecule releases the CO2, it has space available, and it will then pick up the oxygen. The CO2 then, on exhalation, comes out of the alveolar sac and is expelled. Bony thorax. Now, a lot of people think that this moves, but it doesn't move as much as we would think. There is some pliability to it, but most of the time, whenever we breathe, it is a movement of our accessory muscles that we see. The chest cavity itself does not move. It's generally an upward and backward position, the movement of the chest, and this would be from all the muscles that are attached to this rib cage, assisting ventilation. Now, the primary ventilation occurs whenever the diaphragm essentially contracts, and this would be it right here, contracted. Only thing a muscle does is shorten, and it provides negative pressure, which that, with the assistance of all of the muscles that are attached to this, is what brings air in. During inhalation, the inferior part of the sternum moves anteriorly. External intercostal muscles elevate the ribs, and essentially what we get here is we just get an upward and backward movement. And the diaphragm is the major mover, so during relaxation or exhalation, the diaphragm is probably up like this. And during actual inhalation, the diaphragm shortens, thereby causing air to move into the lungs. Lung volume capacities, and this is a brief overview. We're going to talk about it on the next page because I have a nice graphic. They include tidal volume, which is and this is figured off of ideal body weight, 5 to 7 milliliters per kilogram of ideal body weight. Inspiratory, expiratory, reserve volumes, and if we think about a reserve, that would be the maximum amount that we can inhale after a normal breath, and the maximum amount that we can exhale after a normal breath. Alveolar volume would be just simply the volume of the alveoli. Anatomical dead space. The anatomical dead space, there is always air in the lungs as residual volume. Now, this residual volume or dead space, that also means that during inhalation and exhalation, there is going to be a section of space that never got touched by the alveoli or never quite escaped the mouth. And that would be the anatomic dead space. Total lung capacity is going to be essentially your tidal volume or your normal respirations plus this, and this is going to be a sum, tidal volume plus the sum of the inspiratory and expiratory reserve volumes. Vital capacity, we'll talk about that. That's a lot easier to see with the graphic. Inspiratory capacity, same with the graphic. Functional residual capacity. This is what would be kind of leftover functioning air or space that would be left over. Minute ventilation, again, I have some formulas on this graphic that we're fixing to see. And then the peak expiratory flow, and that's pretty easy. We usually use that assessment on asthmatics, and it would be the maximum amount of air force that came out of the lungs. So we look at their peak flow, to determine if they have a reactive airway condition or they are trapping air. And that's what asthma kind of does, is it lets air in, but it doesn't let air out. So these are all of our terms here. So let's start off with tidal volume, and that would be right here. And I'm just going to put in a little X by these as we talk about them. Tidal volume is the volume of a normal breath, and this is approximately 5 to 7 milliliters per kilogram of ideal body weight. Now, most people, whenever they give you their body weight, aren't giving you the ideal body weight. So if you're trying to figure tidal volume, it's very easy to get an ideal body weight chart and just assess it off of there. Start off at 5 if that's not enough tidal volume or that's not enough minute ventilation at that point, and our patient still appears hypoxic, then we increase it a little bit. And this is something we're going to have to kind of do on every patient because we don't know what conditions that they have. So every patient is going to be different. There's not going to be one standard number that works on all of these. We should gauge this to the patient's condition. Inspiratory reserve volume, and I'm going to kind of mark it up here, which is this. Inspiratory reserve volume is the maximum volume that can be inspired above the tidal volume. So a normal respiration, if you can still force air in your lungs, that would be the inspiratory reserve volume. Expiratory reserve volume, the maximum volume that can be expired beyond the tidal volume. So after you've blown out a normal breath, and that would be this one, you still have a little bit of residual volume in there that you can continue to expire. And that would be the expiratory reserve volume. Alveolar volume is very simply the volume of the air in the alveoli. And this is going to be patient condition as well, because if they have emphysema, chronic bronchitis, asthma, their volumes are going to be different. Anatomical dead space is the volume of the conducting airway. So as we look at this airway and all of its little branches that are in here, this may have not reached, and that was supposed to be an alveoli. This may have not reached the alveolar sac. So very simply, all of this conducting system can provide dead space, or space that has never hit the business end of the ventilation. And we've talked about this. Total lung capacity. The sum of the residual volume, the expiratory reserve volume, and the inspiratory reserve volume. So from here to here. And that includes that would be this and this. And that is called the total lung capacity. So that's essentially everything. The vital capacity. I'm going to clear this up so we can see this a little bit. And that was this one we just talked about. This is the vital capacity, which is from here to here. That includes the normal tidal volume, your inspiratory reserve volume, and your expiratory reserve volume. Vital capacity. Functional residual capacity. Air that remains in the lungs at the end of expiration of the tidal volume, and it equals the expiratory reserve volume plus the residual volume. And that would be these two right here. Functional residual capacity. That's essentially if we put pressure into it, or we breathe a little bit more, what would be our functional capacity that would reside in the lungs. Minute ventilation. Minute ventilation is kind of important because it's all based off of surface area. The alveolar sac itself, the more air that we bring across it, and the more gas exchange that we have, the better the respiration. So the minute ventilation measures the volume of gas that passes through the lungs in a minute, and it equals the respiratory rate times the volume of breaths per minute. and that's this right here. The other version of this is the minute alveolar, the alveolar minute volume, my apologies. Minute alveolar ventilation takes into account anatomical dead space. The alveolar minute ventilation is the tidal volume minus the anatomical dead space volume, and then this number is multiplied by the respiratory rate. And this is more accurate because it measures the amount that is in the sinus or the alveoli. Respiratory physiology. Additional concepts. Bony and muscular thorax structures in the pleura. And we're going to talk about this on, I got some pictures following the next couple slides. Normal respiration, negative pressure ventilation, and positive pressure ventilation. We're also going to talk about neurological control of breathing and oxygen and carbon dioxide metabolism. So this is the accessory muscles of inspiration and expiration. So this is why we get so much movement whenever someone takes a ventilation in, and it's because of the use of the accessory muscles. So all of these muscles are moving upwards and backward to allow for expansion of the chest. So up and kind of back. The effects of normal and positive pressure ventilations on the circulatory system. Now we can run down someone's blood pressure very quickly and accidentally sometimes whenever we're ventilating. Now let me explain kind of why. As the interthoracic pressure comes up, we provide kind of a tamponade on the venous system, and this reduces our preload, or the amount of blood coming into our pulmonary trunk, and thereby reduces our cardiac output. So as we have this contracts, moves downward, and air comes in, very simply, the low pressure side, or the superior vena cava, has about 6 millimeters of mercury of pressure. So what happens here is, as there's more air pressure in the lungs, or interthoracic pressure, it reduces that, thereby reducing the amount of preload that would go get ventilated in the pulmonary trunk, and thereby the amount that would get ejected out to the body as well. This is the neurological control of respirations. Very simply, the lower section of our brain is what controls, or we have the respiratory center in, and this has a feedback system between the stretch receptors in the lungs, the heart. Am I hypoxic? The kidneys would be involved here too as well. So, and also we apply some kind of voluntary control over this as well. If we want to take a breath, we can. So if we want to actually take a breath of air, very simply, we can take a breath of air. The involuntary part is always controlled and monitored by the area just below the pons of the medulla oblongata in our brain. Voluntary control, pain, emotions, and temperature also get mixed into this, and very simply will increase our respirations. The chemoreceptors that are also located in the respiratory centers monitor CO2. So everybody that is breathing, we regulate our ventilations off of the amount of CO2 that's in our blood. So as CO2 levels rise, our respirations increase. As CO2 levels lower, our respirations decrease. That's why sometimes a hyperventilation patient will quit breathing. This is atmospheric pressures and a look at how actually an external respiration occurs. Room air at sea level, we have 21% oxygen in our atmosphere. Now, 760 torr is the pressure on our entire atmosphere. Now, that's all the gases that are in that mixture. The partial pressure of oxygen is 160 torr, and we get that by multiplying 760 by 21, by 0.21, and what we get is 160 on this. Room air at altitude, atmospheric pressure. If the atmospheric pressure goes down, in our previous model this was 760, now it's 380, And this would be like if we were at altitude and we multiply the amount of FiO2. Instead of 160, we get essentially 80. Now, what that does is that reduces the amount of oxygen by half that is available to our red blood cells. The reason being is there's not enough pressure behind it. So we would have to supplement the amount of oxygen whenever we are at altitude if we had a patient that was hypoxic at sea level, is my point. Supplemental oxygen, if we added it to 60%, and that's why the percentages of the oxygen are so important to understand, because 2 liters added to our normal atmospheric supply increases the oxygen to about 40%. We can spool that up, if we turn it up to 6 liters per minute, to pretty close to 60%. That would make a lot more oxygen pressure available to the cellular environment. Pediatrics. The pediatrics very simply have a more pronounced occipital area or head. The flexion of their head and neck on a flat surface can occlude the airway. They have a proportionally smaller airway diameter. Now, an adult has an airway about the size of a dime, and it is said that a pediatrics is about 1/3 that size. Their tongue is larger, tonsils and adenoids are larger as well, and they have a more friable mucosa, which means you can damage it a whole lot easier. Floppier and posterior sloping epiglottis, which makes it a little bit more difficult. It's suggested, depending on the size of the child, that we use a straight blade instead of a curved. The larynx position is more anterior and towards the head than it is in an adult, so they have an anterior airway to begin with. Vocal cords are pinker and angled towards the feet, which makes it a little bit more difficult to hit the airway. Airway's smallest level is at the cricoid cartilage. So what that means is a pediatric airway and an adult airway, this is an adult, the glottic opening is the smallest area. After that, it kind of opens up a little bit. So whenever we place the tube in there, there's plenty of room in a pediatric airway. The first cricoid ring is the smallest level, so it kind of funnels. That's why we do not provide, depending on the age of the child, 10 years old, which is the age, a cuffed airway. Very simply, we use an uncuffed tube to provide a friction fit at the first cricoid ring. Airway's smallest level is at the cricoid cartilage. Trachea angled anterior and shorter. More susceptible to gastric distension. So now these two things, the trachea angled anterior, which means that after you see the glottic opening, it goes upward just a little bit, and the overall distance of the trachea is shorter, so it's easier to give them a right main stem. And they're more susceptible to gastric distension. Their chest cavity, depending on the age, and we're talking about really little folks here, like months old, is more pliable. So at the point that we have a lot of air in the stomach, it will push up on the diaphragm and not allow them to ventilate as well to begin with. Now, this pliability also decreases their ability to get air or volume into their chest cavity. This is a nice graphic that I found over the occipital area. Now, in an adult, if we'll notice the occipital area, this angle here is pretty much a neutral inline position. And as we change, this is probably a 10-year-old. As this angle goes backwards more, if we'll notice this board that they're lying on, this child's head is already at the upper limit of that board on this side of it. Same way with this, the angle becomes, this is a smaller child, even still. Angle becomes more severe. Smaller child still, angle even more severe, and then the little bitty ones, big angle. So again, if we'll notice, their head is through the board. So if we moved their head up, if they were lying flat, the neck would be flexed severely forward. Now what that does is that occludes the airway because their airways are softer and mostly cartilaginous at this point. So how do we fix this? If we will pad out their shoulders and bring their shoulders up, it corrects this large occipital area. Corrects this large occipital area. So if you have a child and you should try to get them into a neutral inline position. That may mean that you have to get a towel and place underneath their shoulders to facilitate an intubation. Pediatric differences continued here. Respiratory failure, there's a primary cause of death in pediatric patients compared to cardiovascular failure in adults. Pediatric patients decompensate very rapidly. So if this is a cliff, the pediatric patient will stay pretty normal until they're at the edge of that cliff or they're out of resources, and then they'll just crash. So we have to watch very subtle changes. Increase in heart rate, increase in work and breathing. We need to get more aggressive with their airway control. Pediatric patients have a proportionally higher oxygen consumption than adults, which tends to make them more hypoxic quicker. Pediatric patients have a smaller residual capacity than an adult, which again, they don't have as much reserve to go to. Increased vagal tone in pediatric patients causes bradycardia. Hypoxia in pediatric patients causes bradycardia. So either one of these, if we continuously try to intubate them, we can increase their vagal tone, or if they become hypoxic, both of these will cause bradycardia. At the point that we start seeing bradycardia, we are very close to the edge of the cliff, if not already over it. We need to get aggressive as we possibly can. Conclusion. First step required to achieve efficient, safe, and effective airway and ventilation management. Be familiar with the normal airway anatomy and respiratory physiology, so you got to know what structures you're looking at. And by being knowledgeable about these topics, the effective paramedic can recognize abnormal findings that they see and troubleshoot failures in the management of airway and or ventilation. References for this chapter were found in Richard Beebe's Professional Paramedic Volume 1, Foundations of Paramedic Care, First Edition, and this is pages 352 to 376 of Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@edmson.net, or 405-219-7613. Thank you.